thanks, right now. Thank you very much, Rod. And I'm really pleased to be speaking today because I think, in fact, this is a very exciting meeting. And having just come from a meeting where one of the organisations I'm involved with is FIGO, the International Federation of Obstetrics and Gynaecology, which basically focuses on low and middle resource countries and trying to provide maternity care. And I don't think we sometimes realise how fortunate we are with the data we have so that we can explore the data to improve outcomes. To give you an example, only 5% of stillbirths worldwide are registered anywhere. That might seem a remarkable figure. These countries have no idea their outcomes. So here we are looking at sort of undetected IUG out term and saying, what can we do to turn it around? So we have, I say, it's an extraordinary resource we have. There's very few countries in the world that have anywhere near the data we have. We're amongst the top ones, and I think it was due to foresight of obstetricians and the government agreeing to we have legislation that every birth has to have data registered. That is extremely unusual. I mean, you're really looking at probably Scandinavian countries and Australia. So it's an amazing data resource, and I think it's important that we don't forget that. Oops. So what I was wanting to know is where are we doing less well and what can we do about it? Some of the things I'll be talking about today you've already heard of, but in fact this is a bit of a pet topic of mine, so I'm not sure if that's why I was chosen to talk about it, but you'll understand why as we go along. So indicator 1A is the statewide rate of induction of labour in standard primates, and I'll expand on the standard primate in a minute. It decreased from 3% in 2015 to 3.9% in 2016 in public hospitals, from 13.6% in 2015 to 15.9% in 2016 in private hospitals. So the question is, does it matter? Should we just induce everybody? If we induce everybody, we can get rid of the indicator looking at growth restriction undelivered at 40 weeks because they'll all be delivered. But what will be the downsides of that? So in fact, this was just looking at this perinatal indicator and looking at statewide public and statewide private, and just looking at it again and how it's changed over time. So where's my pointer? There it is. So in fact, yes, statewide public-private, 8.2% in 16-17, public 3.9, private 15.9, for a great big difference. And in fact, the quartile cut-off is 13.2%. So 25% of people go over that. So once you're up to there, you're really sort of moving up the line. So most favourable quartile obviously is ZIP, and in fact statewide public was 3% in 2015-2016. So things have changed and moved on. So what I wanted to have a look at was, what is the risk of continuing the pregnancy? Why do we induce babies? We induce them because the risk of continuing the pregnancy is greater than the risk of induction. So it's one of those very basic principles. So do we know when the risk of continuing the pregnancy is greater than the risk of induction? I'll put it to you that we don't. We have lots of the reasons of risk in continuing the pregnancy, and some of them are pretty soft, like she's a gestational diabetic with normal blood sugars, we better get delivered. Her blood pressure's up a bit, we better get delivered. There's many, many things. They're very soft. The evidence is virtually non-existent, but they're very much part of our thinking and our sort of almost our way of life, dare I say. So the question is, does it matter? And more, as some of you all know, that now, in fact, people are saying induction really doesn't carry no risk. In fact, if you induce somebody, the outcome and caesarean section rate will not be altered. It'll be exactly the same. So having been a private obstetrician for a long time, as a number of you here, and delivered many thousands of babies, this is something that I can't quite accept because, if you induce somebody, especially at primate, and she's not favourable, well, there goes the night. You're going to be out of bed most of the night. So it's hard to actually get over those things, but they say, clinicians are not very responsive to change. I'd like to think I'm not put in that bracket. So what is the risk of continuing the pregnancy? So this is the dear old standard primate that Raz, I think you brought up before. So what value is the standard primate? The standard primate is basically somebody who's so normal, they're medically uninteresting, I guess. So women 20 to 34, so you've got rid of the increased risk of women getting older, given birth for the first time, free of obstetric and specific medical complications, is pregnant with a signal pregnancy of gestation between 37 weeks and 40 weeks 6 days, with a non-small for gestational age baby, and head-first cephalic presentation. Now, one of the limitations of this is, in fact, seems very good, is, in fact, how wide you spread your necks with medical complications. And unfortunately, the way it's been developed over time, which I think is something that we need to review, and I think Mary and I are on the same page as this, is that lots of things. If a midwife puts anything virtually into medical complications like mild asthma attack, she's no longer a standard primip. So what happens is your denominator is getting smaller and smaller and smaller, so you're getting a smaller group. And those of you who look at this on your local hospitals will say, well, look, we only have 2 standard primips. So that must be a ridiculous situation where we're making so many people so complicated, none of them are normal anymore. But having said that, you've then got this little group of people who really, why would you ever induce anybody with those things? There should be no reason. She hasn't got a little bit of this or a little bit of that. Do you do it because the traffic's going to be heavy, or, husband's going to play a golf tournament or something? Is that a reason to induce somebody? So, as I said, there's minimal risk in this group, so really, should we be doing anything? So do we do things? Well, we do things. And we do things very differently in the private and the public sector. And so if we're just looking at these different factors, in 2010, this is a statewide private, statewide public. And you look right the way along the line, sort of changes a bit, but probably not particularly. So here we have, in 2016, the statewide private hospital induction rate, statewide public hospital rate. So we have got over 15% compared with 3.9%. A huge difference. So why is a standard primate less standard in private than public? I mean, as I've said before, she's probably higher socioeconomic class, she's sort of better fed, she's better informed. Is that a problem? Is she too well informed? Is it because as obstetricians we have a conflict of interest because it's much easier to get somebody delivered during the day than at night time? You want to go on holidays, you don't want to leave the whole practice to somebody else. How are these factors? It's very easy for me now because I'm not in private practice, so I can be very rude. I don't want to be rude, I'm just actually trying to understand why that's the case. So the question is, does it matter if they're being induced? Does it make any difference? If you're having your first baby and you're 32 and you're fit and healthy and you live in Hawthorn, how are you going to make sure that you get a normal vaginal delivery if that's what you aspire to? Interesting, in England, when Kate had her first baby vaginally and walked out the hospital looking wonderful about 6 hours later, the vaginal birth rate in England went up, and I was speaking with a woman who's currently president of the British College last week, and she said, oh, great, we're going to have an increase in vaginal deliveries now that Kate's walked out looking fantastic 6 hours post-delivery. We don't all have a stylist on hand, but anyway, apart from that. So in fact, the other thing we need to look at is what about caesarean sections? The thing about these indicators, it's important we overlap them, so we don't look at them in isolation. So how can one indicator influence another indicator? So here we have caesarean sections. So once again, this is not something that's new. I think we all know this, that in fact the caesarean section rate in our private hospitals is significantly greater in our public hospitals. Does it matter? So the question is, does induction of rate increase caesarean section? Now this is very, very important because those of you around the traps at meetings will know that the current truth is that induction of labour does not increase caesarean section rates. So once again, I said, with your experience, you think it's hard to believe this, though there's meta-analyses and there's papers coming out so that if you're over 35, you should be induced, your stillbirth risk goes up post 40 weeks, you'll be in risk, makes no difference. All this sort of factors coming out. When you stop and think about it, it's how we actually get our evidence. So in fact, if you're actually doing a study on induction of labour or not, where do you do it? You do it in a level 6 hospital with a whole lot of people who are actually really primed to run it, who really want, you can't randomise it, obviously. So is there something different, though? Is the Hawthorn effect so great that you're actually changing the outcome? So you've got your evidence, but how well can that evidence be translated to the real world? And that's really what I want to address. So the risk of competing, so what is the risk of induction? So once I said, do we know what the risk is? Now, something that's happened, in fact, and there's what we call these shadow indicators, and if you look at the very last bit of your report, you'll see them there. So one thing we have now is the Robson criteria. And I just like this little graphic of the Robson criteria, it appeals to me. But anyway, as you know the Robson criteria well, they're mutually exclusive, and up here, this little thing means she's come into spontaneous labour, which is rather good. And this is, in fact, the nullus woman with a single pregnancy, it's greater than 36 gestation, who's either had labour induced or delivered by caesarean section. Now, the modified one we've actually got that I couldn't find, Marianne, which in fact the ones delivered by caesarean section before labour are taken out. So that's the modified one. But basically, the data we have, it looks at these two groups of women. So in the real world, does induction of labour at the standard primipara or nullipara, whatever we should call it, I guess, does that increase caesarean section rates? And the Robson criteria is great. It's being used more and more to look at data, and we have this wonderful system. We can look at it and interrogate this data. So we only have it for the last 12 months, and so these are the two that we're looking at. So what does it show us? So, as I've said, these are the two newer indicators, 1B1, and basically they interrogate that data, so I probably won't go on to that any longer. So what did we show? We showed the indicator 1BI, 10-group classification system, spontaneous labour, nulliparous single comparative greater than 37 weeks. Statewide, private and public. This is for induction of spontaneous labour in nulliparous patients. What about caesarean section? So 10-group classification, single-week induced labour, excluding pre-labour caesarean sections. So in fact, if you're induced and you're a standard primip, you had double the rate of caesarean section. This is the real world. So if in our hospitals you're induced as a standard primip, your Caesar rate goes up by double. Now, I don't know how many of you are surprised by that. In fact, could you put your hand up if you're surprised by that, or is that something you've always thought? Thoughts are great, aren't they? Okay, well, it's really a great response, like not. But anyway, be that as it may. So the 2016-2017 data shows that 100% increase in caesarean section in standard nulliparous women who are induced compared with standard nulliparous women who labour spontaneously. 30% compared with 15%. So my message is this. We have to be very careful about just taking articles from the paper, applying them to our population, because by doing that we're doing a disservice to women. Now I know some people think caesarean section is a bad thing. I happen to think it's actually got a lot going for it. Maybe I'm a bit influenced by delivering my own children, finding that, I don't like the word empowering, but quite an experience that I'm pleased I've been able to have. So yes, just saying, please, can we actually start to think that induction of labour is not without its risk, it's not without its problems. We know it makes the whole process longer. We know that some women have to be induced, but not just inducing them because we think it's a good idea. So in fact, say, did induction increase the caesarean section rate? The answer is yes. So my registrars will know that for a long time I've actually suggested that when I fall off this mortal coil, sorry, that was when the rates go up, that in fact my headstone has a certain inscription on it. That inscription is, induction increased caesarean section in standard number in 2016 and 27 in Victoria. Thank you very much.